Go ahead.
This mine works.
How about now? Oh, there we go. It was unplug and plug back in, right? IT solution. Okay. We'll start over. This meeting is called to order. Welcome. This is our first July SEB board meeting of the season. Our meetings this year are going to continue to be hybrid. HCA staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our members of the public attending via Zoom, our opening slide has information about how attendees can turn on closed captioning subtitles. Also, public meeting attendees will be able to activate their audio or video during designated public comment periods. We will control that from our end. For board meetings attending in person, for board members attending in person, please remember to turn on your microphones when speaking so your comments are captured on our audio recording. Let's go ahead and do intros, starting with Myra.
Good morning.
Morning, Carrie.
Good morning.
Pamela.
Good morning.
Terry.
Good morning.
Donna.
Good morning.
Lara.
Good morning.
Omid.
Good morning.
And is Allison with us? Yes, I thought I saw a note saying she's going to be a little bit late. Okay, not yet. And I'm Lou McDermott. And we also have Katie Hatfield from the AGOs. Good morning, Katie. With board members attending both in person and virtually, it's going to be helpful for board members to hold their questions until the presentations are done or when the presenter pauses and asks for questions. Board members attending virtually will be watching for your Zoom hand. With no resolution scheduled for action today's meeting, the public is going to have the ability to provide general comments at the end of the meeting during the public comment period. At that time, public participants are going to need to raise their virtual hand. We'll go ahead and get a list. And again, we will activate your audio and video on our side so that you can provide your comments. As a reminder, if the public has questions during the presentations, there is the email address for the presenter at the end of the presentation, and they can send an email, and we will try and get to that. Sometimes during the meeting, sometimes after the meeting, we'll give you a response. Dave, what's our overview today?
Good morning, Chair McDermott, members of the board. We will begin with a brief executive session just to do some final updates on the rate development process before then we move into the kind of penultimate activity of the board, which is the agency bringing forward the results of procurement, some clarifications on some a benefit change that we need to tee up that is incorporated within the rates that Tanya will then present. We'll ask the board to take action on those premiums next week, but it's the introduction this week and then action next week. And then we'll end the board meeting with me already talking about 2026 and a little bit of shift in the planned board schedule and the way that we organize meetings. I'll walk through that, but trying to get people's calendars already filled for 2026. So relatively short meeting, but that's what we have today. The other things that I would like to highlight is you'll notice and may remember, I thought, Dave, we were going to have some resolutions brought back to vote on related to hearing instruments. We're actually bringing those back next week. We're still working. We've been working on some questions to include as follow-up and just needed a little bit of that extra week time because of since our last meeting straddling July 4th, just production of our materials, just needed the extra week. So still intend to bring the hearing resolutions back, just not this meeting. Instead, it'll be next week. Last reminders, if you need the restroom, you walk down the hall, see elevators, look to your left. If we have an emergency, we walk purposely across the street to the visitor parking lot.
Any questions for Dave? All right, thank you. Before exec session, we're going to go ahead and approve the June 18th meeting minutes. We're going to be voting on that. They're behind tab number 3. Any comments from the board? Hearing none, do I have a motion to approve the minutes as written?
Myra Johnson, make a motion to approve the minutes as written.
Is there a second?
Pam Cruz, second.
All in favor, say aye.
Aye.
Any opposed? Hearing none, the June 18th, 2025 minutes are approved as written. We're going to be transitioning to executive session, which is going to happen here in the Sue Crystal room for board members and include some HCA employees. At this time, members of the public joining us in person at the Healthcare Authority today, as well as employees not part of the executive session, are going to be asked to wait in the lobby during the duration of executive session. You'll be called back to join us in Sue Crystal for the remainder of the public meeting. Pursuant to RCW, this is my favorite part. Pursuant to RCW 42.30.110 subsection 1L, the board will now meet in executive session to consider proprietary, confidential, non-published information related to the development, acquisition, or implementation of state-purchased healthcare services as provided in RCW 4105.026. The executive session will conclude no later than 9:50. Board members, we're starting off with a break. Let's go ahead and take a 5-minute break while we transition to executive session. If you're virtual, please use the separate link given to you via email for the executive session, and we'll see you there in about 5 minutes. The link was sent to you on Tuesday at 12:55 if you're looking through your email, and we're going to then return to our public meeting, continue with the agenda. All right.
And Chair McDermott, I'll just highlight that the executive session will conclude no later than 9:50. We can come back earlier and hold on one second, everyone. All right, everyone, we'll be back at exactly 9:50. No
Well,
earlier, no less.
We'll see you at 9:50. All right, we are back from executive session. And next up, we have Tanya Dool is next up. Oh, I'm sorry. Hang on. 3, 4. I had already crossed your presentation off. Apparently you had already given it. Next up, we have Christine Davis, our procurement manager in the Urban Division, is going to provide us some information on proposed plan year 26 benefit changes for Primera. Materials are behind tab number 4. Welcome.
Thank you. Good morning, Chair McDermott and members of the board. As mentioned, for the record, my name is Christine Davis, procurement manager. And the presentation is aligned to plan year 2026, and it's related to Primera benefit changes. Next slide, please. So to highlight the 2026 benefit changes, it's removing current incentives that promote use of 90-day supply prescription drugs to comply with Senate Bill 5213 concerning health benefit managers. This change is aligned to Primera's fully insured book of business. The next slide will show a table that aligns up with what the changes are. Please note that there is a column for current, which is 2025, and then a column that's aligned to plan year 2026. So here's the table. And so in the lighter blue colored column is the 90-day supply. And the part that I would like to call out is that for comparing 2025 to 2026, you'll note that the column under 2026 is labeled no cost difference for place of service. And what that means is regardless if the member obtains their prescription drugs from retail or mail order, they'll pay the coinsurance that's aligned under that column. And so for high PPO, for preferred generic, you'll notice that the retail copay for 2025 now matches what will be paid regardless of place of service at the $27 level, and it just runs its way down. I don't call it each one individually, but that's really what this slide's intended to call out. And then for the standard PPO plan for preferred brand, there was no change to that coinsurance. So it's not bolded because there was not a change. And just for awareness, how the member can interact with this table is that also knowing that there's a copay and or coinsurance is that there is a deductible that's waived for preferred generic prescription drugs. And for the high deductible, the prescription deductible is $125. For the standard, it's at $250. And then for the HMO plan, there is no prescription deductible. And the 90-day supply for non-preferred generic and brand name will remain at the current 50% coinsurance. So no change across all plans for that. And specialty drugs, there is specific benefit design aligned to specialty drugs that's not changing for plan year 2026. So members, it's not called out in the slide because there isn't any changes, but just to note that for specialty drugs are generally limited to a 30-day supply. And that is the extent of this presentation. Any questions?
Any questions or thoughts?
I'll just highlight for the board that the reason you're hearing about this only in the context of Primera is in the portfolio, their plans were the ones that had an incentive for using mail order. So there aren't other changes to remove mail order incentives or adjust the co-payments for the other plans. Just wanted to give context as to why this is a Primera specific presentation.
Christine, thank you.
Thank you.
Appreciate it. Now we have Tanya Duell. There she comes. We're going to be talking about our 2026 SEB premiums. Tanya Duell, our finance manager in the Financial Services and Healthcare Purchasing Administration, is going to introduce the premiums for next year. No action scheduled on these premiums today. We'll bring the resolutions for these premiums back for voting on our next meeting on July 16th. Materials behind tab number 5. Tanya, welcome.
Thanks, Chair McDermott, members of the board.
Tanya, real quick, I want to clarify my statement from a moment ago because I'm realizing that I didn't give enough nuance. So before you get started, it's also, there are actually some incentives that exist, but it's the nature of of who the legislation applies to and whether and how the PBM relationship exists with the plan. Because I'm realizing, I was sitting here, it's like, no, I think Kaiser does actually have some incentives in their plan. It's really specific to who Senate Bill 5213 applies to in their exact plan structure. But the main point being that the Primera had a specific action that needed to be taken for compliance to adjust incentives. So I did not mean to indicate that there aren't incentives elsewhere in the plan. It really is the target of that legislation. So I realized I misspoke because I was just double checking something. So thank you for giving me that opportunity to clarify. And now I may have prompted a question because Omid, you often ask pharmacy questions. So before we go to Tanya, Omid?
Yeah, I appreciate you clarifying, Dave, because I did have this question beforehand anyway. And it's that I believe, if I'm understanding this correctly, members on this Primera plan could potentially have approximately 4 months worth of prescriptions that were previously covered, and now they're going to have to pay for it. Do we know what the impact will be to Primera plan members and how this will be messaged as folks decide whether or not they want to re-enroll in their Primera plans or switch to another plan where their pharmacy benefits might be cheaper?
So I think your math is planning out. You know, it's basically before a member was getting 3 months supply for 2 months supply. So over the course of the year, correct, they were getting 12 but paying for 8. So yes, four additional months of co-pays that are then built into the system. I know that as we are we're shifting into high gear of open enrollment activities after the board takes action next week on premiums, but there will certainly be conversations with all of the carriers about plan changes, the best way that they can communicate things, how we will communicate things. And I think you're drawing attention to a specific point that I want to make sure Christine focuses on with Primera to think about how best to communicate the impacts of this to members. So there will be anytime there are changes in the portfolio, we do have kind of a change communication process for all parts of the portfolio. And so this will be part of that. But I think you're also highlighting that this can be a pretty substantial change depending on the number of drugs that individuals are taking to really be aware that out-of-pocket on drugs will go up, especially if somebody has multiple prescriptions. So it's definitely a key point for us to draw and work with Primera on best communicating.
I appreciate that. Thank you.
And now we'll turn it back to Tanya and premiums. Sorry.
All right. Thank you. All right. Next slide, please. Just a brief reminder of our annual renewal timeline. So this process actually starts back in February when we are working on and releasing the RFR. RFR is our request for renewal that gets sent out for our carriers to respond to. May 1st, we get back our first round of premiums and bid rates from our carriers. And then we try to finalize rates by the very end of June so that we can be here presenting rates to you today. So today we are going to present the proposed 2026 employee premiums with asking you to authorize those premiums at the next meeting. First, we're going to just do some level setting on how the employer contribution is established. Next slide, please. So as defined by the collective bargaining process, we use what we call an EMC, the employer medical contribution, to determine how much of the rates the employer will pick up. It says in the collective bargaining agreement that the EMC will be an amount equal to 85% of the monthly premium for the self-insured SEB UMP Achieve 2 plan. So UMP Achieve 2 is the benchmark for the employer contribution for all plans. So how this works is we look at the UMP Achieve 2 bid rate. In this example, it's $800. We multiply that by 85%, and we determine that the EMC will be $680 for this illustrative example, meaning that the employees for UMP Achieve 2 pick up the difference. So $800 minus the EMC is the employee contribution of $120. We take that through the next step and we look at all of the plan bid rates. So in this example, we have plan bid rates ranging from $800 to $725. So regardless of the richness or the value or the price point of that plan, the state contributes the same $680. So if an employee chooses to enroll in a more expensive plan like Plan A at $800, employees in Plan A will pay $120. Whereas if we look at the far right, Plan C, if an employee chooses to enroll in a lesser expensive plan, the state still contributes that same $680, meaning the employee pays $45. These are all single subscriber numbers. So when we look at the next slide, this really rolls it through all of the various tiers that employees can enroll in. So we'll just focus on Plan A. So Tier 1 is that single subscriber, which is the employee only. It's just times 1. So the 120, when you add a spouse or state registered domestic partner and you multiply it by 2, that employee pays then $240 for them and their spouse. Tier 3 is multiplied by 1.75, and this is the subscriber, the employee, and their child or children. So regardless of the number of children on your account, you would multiply the single subscriber rate by 1.75, meaning that employee would pay $210 to cover them and their children. And then the final Tier 4 is the subscriber and spouse or state registered domestic partner and child or children, which is multiplied by 3. So 120 times 3 is $360. And this math follows through for all of the carriers and all of the plans. So on the next slide, we'll look at actually the proposed 2026 bid rate, EMC, and employee contribution math. So how this is laid out is by carrier. At the top, we have our Kaiser Northwest plan offerings, followed by our Kaiser Washington, the Kaiser Washington offerings, our Primera offerings, and then the Uniform Medical Plan. On the first set of numbers on the left with the kind of brighter blue that says bid rate, this is the total rate. You can see that the employer contribution in the middle is the same. So regardless of the plan's bid rate, the employer contribution is the same. And for 2026, it is $766. So when you do the math of bid rate minus the employer contribution in the middle, the far right column is the remainder, which is picked up by the employee. And these are single subscriber numbers. If you wanted to do the math, you could go down to Achieve 2, see the $900 bid rate, times it by 85%. That's where we get the $766. I think the next slide is really where we wanted to kind of pause the most. I think this is the kind of most telling slide. The carriers are laid out in the same order with the plan offerings for each carrier. However, this slide compares the 2025 current employee premium, so what the employees are experiencing today coming out of their paychecks, versus the proposed 2026 rates. And then the next 2 columns are the year-over-year change. So when you look at what the employee is paying today versus what they will pay next year if they remain in their same plan, and that percentage increase. I do want to kind of bring us back to the EMC comments just a little bit. So when the EMC increases at a set rate, so for UMP Achieve 2, you can see that it increased by 8%. The bid rate increased by 8%, meaning the employee contribution increases by 8% because of the dynamic of the EMC. When plan bid rates increase above UMP Achieve 2, that means that the employees pick up that remaining increase above and beyond that percentage. If you have a plan that comes in at an increase lesser than Achieve 2, you can see employee premiums actually decrease year over year. In this case, we have employee premiums going up for all of our plans. On the far right columns, you can see the total membership enrollment for all of our plans. We thought that was helpful. And then, so what is in front of you today is our final round of rates. Like I mentioned, we start the procurement process May 1st. We go through multiple rounds of negotiations with our fully insured carriers. As a reminder, for the uniform medical plan, we are not negotiating with regions. We have a set administrative fee for regions, but HCA with our contracted actuaries actually determines the rates for UMP. So we are doing that on our own little negotiation with ourselves. But we do negotiate with our fully insured carriers. And the rates that you see in front of you are the carrier's best and final rates that they were able to propose to us. So while we negotiate over many months, and really strive to bring you the best rates possible, it was a bit of a journey this year to get to these rates. While that process of negotiating was the same, as it was every single year, it was a bit different. What we are bringing to you is some larger increases than we have historically seen. And what is being presented after all of these rounds of negotiations really is coming in at a better place than where we started. I want to pause here for any questions before we move to the next slide.
Quickly, I'll just remind folks that UMP Plus is not on this sheet anymore. That is the embodiment of the closure of that plan as required by the state budget. It's also a great opportunity to remind you that there are no plans for 2026 today. As we sit here right this moment, until the board affirmatively approves with a majority vote a carrier set of plans, including the uniform medical plan set, no plans exist until you affirmatively vote. So it's a clean slate right now, and that's where by not presenting you a rate on UMP Plus, then that plan will not exist because there is no rate and plan authorized by the board at that point. So it's not that you have to affirmatively close the plan. We're not teeing up a rate for you, and therefore the plan can no longer exist. So just reminder of that. Pam?
So I'm seeing these rates, and maybe this will come up on another slide. A lot of our plans have a high deductible. Do we have a document that shows what that deductible is? Am I just missing it?
You are not missing it. I can add that when we bring back the final resolutions onto the front end of the slide.
Okay.
I can add it for you. Is there a specific one you had a question on?
Well, when I look at we talk about that high deductible, and I guess, I'm thinking of some of the staff that work with me.
Yeah.
And, I don't know all of these off the top of my head when they're sitting in my classroom saying, gee, what should we do? And I want to say, well, here's your out of pocket per month. What is your deductible? What kind of things? What is your family situation? So I was just like, I know what mine is, but I can't say it for every plan.
Yeah. I will add it for our final slides when we bring them back to you next week for resolution, but I will say that our communications that go out do list the deductibles and premiums. So we will, make sure that that is in our member communications. And then just for reference, because it always is backwards in my head a little bit, but when you're looking at, for instance, the Kaiser plans, the Summit 3s are the Summit 3, the Core 3, and the Kaiser Northwest 3 are the lower of the deductibles.
Okay.
And as you go up to 2 and 1, they become higher deductibles. It's always backwards in my brain.
Works for me.
Yeah.
Thank you.
Yeah. Okay. So we included a new slide on this next slide that I haven't had historically, but I thought it would be helpful because we do have some new board members who have not been here. But it's showing the employee contributions over the years since 2022. So 22, 3, 24, and the proposed 25 rates or 26. Jeez. No. So this is new. Just wanted to provide some context. This really kind of illustrates what members experience when they stay in their same plan. Some of that volatility in the member premiums that could, really kind of urge members to switch plans. So we really wanted to just include this as some additional context of those year-over-year premium changes.
And this is the single subscriber rate. So you have to use the tier factors to see the impacts for adding dependents. So single subscriber, 5-year look back.
Terry, you have a question? Can't hear you, Terry.
You might be on mute.
We're pulling you back in, Terry, so that you have audio speaking capacity.
Sorry, that was an inadvertent hand.
Okay.
All right. And then the next slide rolls all of the single subscriber employee premiums that we just walked through all of the various tiers. So like I described, the single subscriber tier is a 1, subscriber and spouse is 2, subscriber and children's 1.75, and the subscriber spouse, child, children tier is times by 3. So you can see what each employee, regardless of their kind of family makeup, will be paying. The next slide, we did want to acknowledge that there were some alternative proposals that were presented to the board by some of our carriers, which included increasing some member out-of-pocket costs. And we wanted to kind of talk through like what those types of changes could look like. While this isn't a specific example or proposal from any of our carriers, this is just an example of some of the types of things that we can receive for these types of proposals. In this example, this shows the reducing of the monthly premium by $20, which is $240 annually. But by increasing the deductible, or by reducing the premium, they look at increasing out-of-pocket costs. So in this one, it would increase the deductible from $200 to $500, which is $300 additional in deductible. While not everybody is going to meet their deductible, if you were, this would not math, right? An increased deductible of $300 and a reduced premium of $240. Some other options include things like increasing coinsurance and things like that. So on the next slide, we wanted to talk about why those alternative proposals are not being brought forward for board adoption. While changing the benefit design and keeping those same plan names without an active open enrollment could result in members experiencing unexpected plan costs. We believe members largely without an active open enrollment just kind of have a passive open enrollment and shop by premium. So when it's changing a premium but increasing out-of-pocket costs, members could have unexpected out-of-pocket costs if they are not paying attention to the full suite of changes. And then we also believe this, it kind of erodes the value of the plans. So we really wanted to focus on premiums and not shifting those costs into the out-of-pocket. Dave, anything to add on this one?
Yeah, I'd love to hear anything from the board about kind of the thoughts around this, because it is a fundamental philosophy when it comes to benefit design is the potential predictability of premiums on a month-to-month basis versus the variability that can happen with out-of-pocket expenses. I mean, there's the other component, like Tanya said, is members often stay in the same plan year over year. Introducing another plan that has different cost structures that they can kind of move into is maybe a different approach than changing the fundamental pillars within an individual plan. But there's a lot of concern with in both programs. There is a lot of retention within the same plan year over year. And while we always strive to get people to look beyond premium at deductible and out-of-pocket maximum, we also know that there's just there's a substantial number of people who don't do that, and they go, what I had last year, it's the same name, it must be the same product. I know premium changes, but they don't necessarily expect fundamental shifts in the cost structure of their day-to-day experience for point of service expenses. And so that's a kind of an important value proposition that I'd love to hear some conversation from the board about. Pam, you look ready to pounce.
Well, you said a lot of what I was thinking, but I appreciate, you know, I think of the paraeducators I work with. They're young and haven't had as much life experience yet, or had to think of what kind of healthcare am I going to need as I age. I'm the mom of the group. I want to take care of them. But it concerns me that yes, we do look at those premiums, but that example you gave where it's actually the deductible, I'm gonna see if I can say this right. Looking at the deductible is actually sometimes more beneficial than the premium. Am I making, yes,
Yes.
I said that right. Because, I remember being 21 and going, oh, I don't want anything out of pocket. I'm healthy. And in my first year of teaching, I had to have major surgery. Who knew? And killed my healthcare that year. But I don't want it to be a bait and switch. I don't like it. It's not a good feeling. We need to have healthcare that helps everybody, and we're not trying to play the shell game and move things around. And then I had a question about a previous slide. On the historical employee premiums, what happened in 2024? Because I think I was on the board.
Yeah. So
You were, I can say that
You
for sure.
were.
I know that part. Back to Tanya, you were.
2024 was a rough year.
Was that the rough year?
That was the rough year.
Okay.
Yes. There was a couple things that happened, specifically we had Kaiser attend some of our board meetings. That was a
That year.
That was a
Okay.
year, yes, that we did have some significant rate increases. And if you're looking at UMP, also 2024, never mind, wrong board. I was gonna say for sure the EMC. But yes, that was the year.
So here's my question on that then. I'm sorry. I didn't
Oh,
interrupt you.
no, go ahead. I was going to make a comment the previous.
I can see, I think it's KP Washington, the Summit one. I see $100, 2024, yet they brought it down the following year. So if they can do that, shouldn't the rate stay low every year? If they could find it, I'm just saying, and if you're in a pickle to answer that,
No.
I'm saying theoretically, if you can find it to bring it down, you should keep it down.
I will say, I don't know that it's necessarily about finding it. There's a lot of things under the hood that happened between 24 and 25 that caused some of their premiums to decrease that were not specifically about the carrier's required revenue.
Okay.
Remember, there are things like risk scores that go into this conversation, and the changing of required revenue versus risk scores has an impact on this. So I will say it's not necessarily about finding it. There are additional things that I think we probably would need to talk about in an executive session. But I appreciate your comment. I think there's a balance to it.
Yeah.
And one comment I wanted to make about what we talked about, the bait and switch thing. The part of the issue I see is that the complexity of healthcare with your deductible, the coinsurance, the cost share, the premium, and that sort of balance, and your life circumstances. Of
Yes.
course, your first year of teaching, you would not think you're going in for major surgery, but there are other tools as well between the FSA, the HSA, how these different tools work. And I do think it would be incumbent upon the agency to come up with a wizard, something that would help people sort of sort through all those things. But it is so individualistic. And
Yeah.
for a 22-year-old, some of these paralegals you're talking about, to anticipate a major surgery would be odd. Be like, oh, well, what if I have a major surgery this year? It's like that'd be odd. And so it does only really work for people who have sort of predictable things that are going to happen during the year.
Exactly,
The
yeah.
unpredictable is tough because you're just like, why am I going to pay this big premium to keep my cost share down when I'm not going to the doctor this year? And then you do, and then all of a sudden you experience all those. So it is a significant problem, and I don't think there's a super answer for it. It's a thing. Allison?
Yeah, thanks. I'm appreciating this conversation overall, and I think this historical employee premiums is really helpful. does the deductibles, and if we were taking that example of 100 to 40, are the deductibles at the same level from 2024 to 2025, or is it kind of helpful to be thinking about employee contributions and deductibles at the same rate of growth or decrease in that way?
So other than the UMP high deductible plan, I don't believe we've had any deductibles that have changed since the launch of the program. So the IRS qualified aspect has forced UMP high deductible plan to move up, but otherwise the deductibles have none have been changed. There may have been proposals to change them, but none have actually been changed over time. And so the deductibles are coalesced around four specific numbers. Plans either have 125, 250, 750, or 1250. That's excluding UMP high deductibles. So those are the four deductible numbers. So those have remained constant. And I think, I do want to say, I don't think anybody's saying that the carriers have proposed something as a purposeful bait and switch. It's how the consumer might perceive it on the back end. And so I just want to be clear that I don't think anyone's here is saying that that's the intent of the proposal. I think the carriers say, hey, we know people premium shop. Here's a way to offset those premium costs. One of them is through cost shifting. And the way that I'm hearing is that there's concern that consumers might feel like that's a bait and switch, not that that's anyone's intent. So I did want to say that, but for complete clarity. And did I answer all of parts of your question, Allison?
Yeah, I was just going to make a further comment on that, mostly to the complexity of trying to understand, this is a lot of plans with kind of similar names, and you sort of got to be looking with a pretty critical eye about the differences between that. And so just sort of reinforcing the tools that the agency can provide, both in the kind of mass communication that we do, but also, excuse me, for the benefit administrators to have, good or easier ways to decipher this, I think would be really important.
And Dave, correct me if I'm wrong, but I believe the collective bargaining agreement, does that lock in the deductible at 250?
Only for Achieve 2.
Achieve 2. Okay.
The benchmark plan is locked in for shifting costs from the employer to the employee.
Got it. And that's
So put a finer point on it, there can't be a net change in cost shifting. So there can be changes, there just can't be a net shift to the employee. But that is specifically about Achieve 2 as the benchmark for the funding from the CBA.
And another complicating factor when you consider all the levers and what our ability to modify. Yep.
I saw Omid first.
Omid?
Hi, everyone. I just wanted to echo what everyone's been saying so far. I think it's very difficult to message changes in premiums versus deductibles, especially I work at my research is in health policy, and I'm a medical provider, and it's still like confusing to me sometimes how I can message this. And my dad, for example, the other day asked me about his Medicare benefits, and I know that's a whole nother headache of its own, but just to say, like, it's already complicated for those who have a baseline knowledge of it. So to then further ask someone who is like quickly making a decision based on the premiums, it's a big ask. And one other thing that I hope the board can consider to do is, as plans consider cost shifting, particularly, I know I have a bee in my bonnet around prescription cost changes year to year. As plans make their changes and shift the costs, it would be great for members to also see this is how, if you continue in your plan, your costs will change if you stay here, and have them have the ability to make those options. So in that sense, if plans decide or want to cost shift in different ways, that's well understood by the members, particularly based on how they access health services in the year before. But I appreciate the board's attention to cost shifting measures and recognizing that on a net, it should always balance out, even if it is at the expense of not showing that premiums are artificially coming down. So I appreciate that.
And Lara?
Hey everyone. I just also want to echo some of the comments that have already been discussed. Specifically, when we see a lot of volatility in the premiums from year to year, so that year from 24 down to 25, what we had to deal with as benefit administrators is the question we get, because I mean, let's be honest, our employees are premium shopping. But get a lot of questions like, what am I losing? What changed? Is it the network, or is it some cost shifting that's occurring? So it does just take a lot to explain those types of things to employees when we see some volatility in the premiums. They just want to know, what am I losing? What's changing? Because really what they're looking at are just the premiums. They're not looking in depth what's changing within the benefit design. And then just echoing again how the agency can support benefit administrators in educating employees. As much as I'd love to sit down with every single employee that we have, we don't have the time. So, when one board member saying she, helps those paraeducators pick their plan and those kind of things, we get employees that want us to help them sit down and pick their plan, but we just don't have the time in a district our size. So, I know there's the benefit fairs and those kind of things, but the members are asking for, who can I call? Who's someone I can explain my situation to? So that's just one thing I'd like us to consider. Again, I know before we had the Ask Alex thing that was kind of helpful, but there's not really a dedicated number that employees can call or sit down with someone to go through their plans or their specific situation. So they really rely on the benefit administrators, and it really inundates the BAs too. So just something to keep in mind.
Laura, the way you gave a comment, I have a question for your experience with you and your fellow BAs. You're like, the proposed premiums here are keeping benefit design stable. Am I correct in assuming, because you said like one of the questions you'll get asked as a VA is what is changing? And it's probably easier to communicate. Actually, the structure isn't changing. This is the true cost of the increase you're seeing is kind of the overall increase in the actual plan that you've always felt and experienced. There's not changes underlying it. It's the cost of the plan. And that is an easier message than, well, some of it's downward pressure from this and some of it's upward pressure from this, and you're going to experience that. Isn't it easier?
In a year like this year with it's just, a cost increase and we aren't seeing benefit design changes, it's a little easier to explain. And I think employees anticipate an increase. So in the 2025 year, when we saw premiums actually go down, it was more difficult to explain, because you would think with a benefit or with a premium decrease, the thing that they automatically go to is, well, what am I losing, or what's changing? Why is it going down? That's not what they expect.
Thanks, that's helpful. I saw Carrie reaching for her mic.
Well, I don't have anything specific to add to this other than the concern that if we go to the idea of changing plan design to do something to moderate premium, because that's a nice message to say we have moderated premium, I think the confusion, I think the risk to people is significant, and everything that we can do to keep the plan designs aligned and consistent and clear and not have and as much as possible keep networks intact and things like that, so people can really make the comparison. So I am concerned that as we go forward, that we're able to keep our plans aligned and the designs aligned and the message about what it is you get in those plans clear, so that you really can accurately evaluate premium.
And I see Terry's hand up.
Yeah, so kind of to piggyback on Laura's comments, is there a central place? Is there somebody that can answer questions besides the benefit fair? Because I don't know that enough people take advantage of the benefit fairs. people who want to switch but are reluctant because they're in the middle of treatment or have a family member who is in the middle of treatment or is afraid they'll have to start all over again on the tier cycle with medications. It just seems like certain plans tend to put people on a bit of a roller coaster ride each year. And I think what people are looking for is even stability within their plans, if that makes sense.
Well, to one of your questions, that is, what resources exist to help the individual member? Both the PEB and SEB programs are fundamentally set up as like a decentralized administrative process when it comes to the employee experience. The agency is charged with helping the boards and managing rulemaking and doing the procurements and doing the central purchasing aspect of the programs and the framework for eligibility and enrollment and managing the systems, but not assisting the individual member. The staffing model, even for PEB back into the 90s, never included resources for a central agency to be the navigators of healthcare for even state employees when we talk about PEB from the 90s. So even today, the experience that benefits administrators have at school districts is similar to what state agencies and higher education institutions experience and have experienced in the PEB program. So there's not a central toll-free number to this agency for employees of either state agencies, higher education, or school districts for that type of assistance. The model that was created by the state has always been the home employer is the best place to answer individual questions. That's why the eligibility determinations are not centrally done in Olympia, but they're done at the home employer, and that their circumstances might be best able to be kind of questions would be best answered there. That is a model. It is, as you point out, there's like the staffing resources will vary from agency to agency and school district to school district, and the ability to provide additional type services. Does that mean that a different model couldn't exist? Of course, a different model could exist, but there would need to be significant more staff at this agency to have that navigator of healthcare or navigator of the portfolio. We do that for retirees because that was staffed. You know, when an employee leaves the workforce and they retire, they no longer have a home employer. So for retirees, whether they come from K-12 or state agencies or higher education, HCA, for all intents and purposes, becomes their home employer for purposes of navigating retirement healthcare. So we do have a 1-800 number. It's dedicated for retirees, and also COBRA self-pay because we're doing central COBRA administration, which everybody loves. None of that was one thing ever. It was the only like universal praise of the SEB launch I think I heard from districts was thank you for taking COBRA on for us. So you know we do have that process for navigating the portfolio for that subset of individuals, but we aren't staffed, and the program has never been designed to do that. That doesn't mean that it can't be done. It just hasn't been done at this point. So I think, you know, we can have ongoing conversations about what it would take to build up a staffing model. But for example, we have 115,000 covered lives in PEB retirement and PEB Medicare plans, and PEB non-Medicare plans. And we have a call service center of about 30 staff. We have a total of 790,000 lives between PEB and SEB. And so we're talking significant potential staffing levels that would be needed to support. And the service levels that we provide to our retirees can always be better. Especially during where we have peaks and valleys with regards to response times and wait times, and there's always frustration in that area. We're always trying to change exactly how we do our training, you know, how we're hiring staff, when we're hiring them and training them for open enrollment to try to mitigate as much as we can long open enrollments, long wait times. Long wait times will always exist to a higher extent during open enrollment than other periods because we don't staff in a way that has peaks and valleys. We have a stable staff throughout the year. And so that means, you know, it might, you know, there's projects that can be worked on in one part of the year, and then there's longer wait times in other parts of the year. But that model doesn't exist for school employees at this point. And this agency would need significant more staffing, just as all the home employers say, I don't have the staffing to do this either on an individual basis. This agency, the programs were never set up to do that function in their inception to begin with. Again, doesn't mean that that can't change in the future. It's just not the model that is funded for the central program.
And Laura has her hand back up.
Yeah, so along with what Dave is saying, I understand the agency doesn't have the staffing to support that. And the district obviously doesn't either. But when we came from school districts procuring their own benefits, a lot of districts had insurance brokers that could, assist with those level of questions. When I get an employee that asks me, okay, well, which plan covers weight loss medication? Our staff, they have other jobs that they're doing, whether it's, a bigger school district and it's the payroll person that is also managing benefits, or a smaller district where they are in charge of the entire school district's budget and benefits. It just makes it hard because we don't know the plans, and we're expected to be able to answer some of those questions to the nitty gritty, and we just don't have that level of information about the plan. So that why I just want to echo what Carrie was saying too about keeping the plans pretty similar in their structure from year to year and not be making changes in the benefit designs, the deductibles, those kind of cost shifting things that were proposed, because when those things are happening, people are premium shopping, they're not paying attention to those other things that are changing, and they're not on anyone else's radar. So
thank you,
just
Laura,
wanted
for
to
kind
add
of
that.
bringing it back to the question that we were working on, which is like stability of the plan design also
Yeah.
helps lessen the pressure on the lack of resources that exist everywhere.
Yes. Thank you.
Any additional medical questions? Because the next slides start going into some of the other benefit offerings. You can still interrupt me later if you come up with something.
We go back to prior presentations like I modeled earlier.
Yes. All right. So let's move on to vision and dental. As a reminder, vision and dental are 100% employer paid. Employees do not pay a premium for vision or dental. So we have our 3 vision carriers as well as our 3 dental carriers. On the screen is the rates through for 2026. Just a note that vision has a rate guarantee through 2027 and dental will be a 3-year rate guarantee through 2028.
And the board, we don't tee up resolutions on employer paid benefits because the board's authority is about authorizing employee premiums. But we share them with you because these also are proxies and for the COBRA population if they're self-paying.
All right, next slide is life and accidental death and dismemberment, AD&D. So we have a basic and a supplemental life and AD&D. Employer funded basic has no premium change. Neither does the employee funded for 2026. Unless an employee transitions in some of the age bands, then their supplemental rate could change. These rates are guaranteed through December of 2029. On the next slide is just a quick summary of the LTD changes. These are actually Kimberly's slides from what she presented last month. So as a reminder, the board took action to increase the employer paid LTD from $400 to $450. And these come with a slight decrease for the employee paid premiums, which are on the next slide. I'm not going to focus on these because Kimberly did an entire presentation on LTD.
But I will highlight that when you voted on the benefit design resolution a couple of meetings ago, that sometimes you vote on the benefit design and it spits out a rate because the rate is the embodiment of the benefit design. Other times we have you vote on the rate and it is the embodiment of the benefit design. So because there was an impact on employee premiums, you in fact did endorse these premiums implicitly when you made the benefit design change via the benefit resolution. So that's why there's not a separate resolution on LTD.
All right. So that is it for premiums. Up next are just the proposed resolutions. I will save you all from me reading through each one of these, but they read the same. So what we have an example of on the screen here is the proposed resolution SEB 2025-05, which is the Kaiser Foundation. I think health is missing from that title.
Yep.
Of the Northwest. So the SEB board authorizes the Kaiser Foundation Health Plan of the Northwest 2026 employee premiums. So at the next board meeting, we would ask the board to authorize a premium for each of the carriers. And by the board authorizing the carrier resolution, it adopts the premiums for the plans that we talked through today, as well as the underlying plan design that some of it has been sprinkled along the journey here. For example, a reminder of the high deductible increase because we follow the IRS. Christine's presentation on the pharmacy change for Primera. Those things are all included by the board authorizing the premiums for that carrier. And like Dave noted, for UMP, because there was no UMP Plus plan, premium presented, the Plus plan will not exist after the board authorizes these premiums. However, there is language from the legislature in the appropriations bill that says the plan will not exist after the end of this plan year. Questions or comments?
Anybody got anything for Tanya? All right, Tanya, thank you.
Thank you.
Appreciate all the work that went into that. It's been a long season.
I thank my team. They worked really hard this season.
Excellent.
Awesome. Thank you.
All right, next up, Dave's going to go over the 26 calendar with us. Materials behind tab number 6.
Still good morning, Chair McDermott, members of the board. So near the end of the season, we bring you the proposed schedule of the next year's sub-board meetings. These are ultimately formally filed with the code revisor to comply with the Open Public Meetings Act. But there are a couple of differences in the structure and the cadence of this meeting schedule than the past, especially for this year and from prior years. And so I wanted to highlight 2 distinctions in this schedule. So first of all, nothing different. We always propose almost an all-day retreat for the board near the end of January. And then we start off kind of the beginning of March, we have a board meeting. At the beginning of April, we have a board meeting. So everything should be very familiar. This has not been changed since the program launched. The beginning, we start to get into the early parts of May. It's where we get into June and July where there are some changes represented here. So in June, we historically have 2 board meetings. We usually are trying to stagger PEB and SEB on different weeks and consistently having Thursday meetings for everybody because Thursday is board meeting day, and there's a cadence that comes with that. And so what happened in June is first Thursday and third Thursday would be SEB, and second Thursday and fourth Thursday would be PEB. But what we're finding is the third Thursday, the week that has the third Thursday is the week of Juneteenth. And as the state has moved to recognizing Juneteenth as a state holiday, and school districts trying to balance and hit not knowing exactly how many bomb cyclones there are going to be or snow days there will be, depending on where you are in the state, that trying to target having the school year end on or before June 15th, or Juneteenth, or that week. So we thought it might be best to try to avoid having a board meeting that week. Many of you are parents, many of you are actual employees of school districts, and we thought that flexibility might be desirable, and just kind of facilitate. That's a tough transition. I hear, not as a parent, I hear it's a tough transition that time of year. So trying to give a little bit of relief to everybody who wants to participate in board meetings, both board members and the public. So we've actually shifted that second June meeting to the 4th Wednesday. So it does shift back to Wednesday and get away from a Thursday because we'll keep our PEB meeting and our retirees who are very engaged in our public meetings on the Thursday schedule. But we are specifically shifting out of the third week of June for the purposes of what's happening in districts and the end of the school year. The other pieces in July, you see things like starting at 1 p.m. We haven't had afternoon meetings for the board, but rather than shifting to Wednesdays in July, leaving it on the Thursday schedule. And for the agency, we would have PEB in the morning and SEB in the afternoon. We're feeling that generally confident that the duration of the meetings is such that we could do half-day meetings. It's a long day for us. We have to shift at the lunchtime and switch hats, but we thought that predictability and keeping everybody on a Thursday schedule as much as possible and just kind of having a full board day for the agency's purposes would help facilitate kind of the consistency of the experience. So rather than shifting from Thursdays to Wednesday 9 a.m., we'd keep it on Thursday but shift to 1 p.m. So generally this schedule represents Thursdays except for the last June meeting, but this schedule accounts for the Juneteenth holiday and the end of school year closures, and then trying to keep this board on Thursdays as well. So that's the proposed schedule, some of the nuances that go into this, and just kind of highlighting for you that this is the proposal. Wanted to bring it to you. Hear any comments, concerns. We'll bring it back next week just as at the final meeting, and then after that we'll publish it, and then there'll be official meetings.
Any questions or concerns?
I saw some good head nodding.
All right. Next up, public comments. So we're gonna see if anyone in the room wants to make any public comments. Seeing none, and now we're gonna go out to Zoom land. And if you're a member of the public and you'd like to make a comment, please raise your Zoom hand. We will identify you, and then we will give you the ability to undo your audio and video for comments. Going once. Going twice. Seeing no hands up, then we are done with public comment. That was a light one. Jeez. I was like, we've had somebody comment every single one. Okay. Still on? Okay. Our next, feeling kind of like a little unsatisfied here, but
What you went
yeah,
for.
understood. Our next meeting is going to be July 16th, starting at 9 a.m. with the same format of attendance in person or via Zoom. Dave, any comments before we adjourn?
Again, next board meeting is next Wednesday at 9 a.m. So continuing Wednesday this year. Topics that we anticipate for what is hopefully the final meeting of this board season are bringing back the resolutions related to hearing instruments for the Uniform Medical Plan, the premium resolutions that Tanya just introduced. We are in full open enrollment gear. I think last time I think I highlighted we were like 121 days, but then somebody reminded me I should do business days. And so we're at like 77 business days from open enrollment, which sounds extraordinarily scary. But it really reminds us as to why the board season can't go on for much longer, because it's not that far away. But we'll have an open enrollment readiness. We always have a kind of a presentation to shift towards that direction. There's been questions from the board in recent months about what it might look like to expand the portfolio offerings in the medical space. And so we'll have a presentation about like what that process looks like, and then take final comment from the board about the board meeting schedule. And so that's what we're anticipating for next meeting. And I see a question from Laura.
No, sorry, not a question. I just wanted to say thank you to Tanya and Dave and everyone that worked on those premiums with the carriers and everything. Just, I know the work you do is difficult, so just wanted to say thank you.
Thank you.
I'd like to double down on that as well. I do know there's a lot of work that goes into all these presentations, the negotiations back and forth, all the calculations that are done, plan design, things that are reviewed, everything that goes into getting us to a final rate and a final resolution. So Dave, thank you to you and your staff. Thank you to the board, always providing good input and participating, and that helps a lot. There are some extremely quiet boards where it just is sort of a one-way street. And so it's nice to get some feedback on things and how things are going. So really appreciate that. Dave, anything else? Anything else from the board? Thank you all. Oh, no, I saw something else. Thank you all. Safe travels, and this meeting is adjourned.